This topic is tuberculosis. Tuberculosis, or TB, is a highly communicable respiratory disease caused by Mycobacterium tuberculosis, and it's spread through aerosols, not contact. Aerosolized particles are very small and remain suspended in the air for a long period of time. So as you can see in the graphic here, it's a lot easier for a healthy person to be infected with the bacteria that causes tuberculosis. Let's talk about how infection actually occurs with TB. When TB enters the body, it's going to go to the lungs. If someone is healthy or the amount of exposure to TB is minimal, the body is going to create a wall or a fence around the bacteria, and it's not going to affect anywhere in the body. There's not going to be any noticeable signs of infection, and this is known as latent TB. Now, if clients are immunocompromised when exposed to TB, or if they've had TB in their body as a latent infection and they eventually become immunocompromised, it can reactivate and become active TB. In active TB, that fence is simply not strong enough around the bacteria and it begins to spread, first to the lungs and eventually to other organs of the body. As I mentioned, latent TB can reactivate and cause active TB. This can eventually progress to miliary TB, which can involve any organ, and most commonly the brain, liver, kidney, and bones. So you can see in the graphic, when the bacteria is reactivated, it begins spreading quickly through the lungs, and it eventually spreads to other organs. Little milia are formed, so it's called miliary tuberculosis. TB can also cause pleural effusion or empyema as it spreads. Bacteria is going to cause damage to tissue and may even kill off some lung tissue. If the body recognizes this damage, it's going to send things to the site to try to heal it, and fluid's going to accumulate. Because TB is so easily transmitted, there are a lot of risk factors, and the biggest is immunosuppression, such as clients with HIV or those receiving chemotherapy. The body is just simply unable to fight off things, and so when a bacteria is introduced, it's going to easily colonize. If clients have recently traveled to areas where TB rates are high, they're more likely to get it. Unfortunately, in resource-poor countries, rates of TB are very high. Along the same lines, if someone's been exposed to another person with an active TB infection, they're at risk for developing it themselves. Finally, clients who live or are in facilities where they are in close contact with other people for long periods of time are at risk for TB. Remember that TB is spread via aerosolized droplets, and these are going to remain in the air for an extended period of time. If places are densely populated, such as in a prison, homeless shelter, or a healthcare facility, like a long-term care facility, clients are more at risk for developing it. The bacteria is simply in the air longer, and there's a lot more people around, so the risk of it getting to more people is very high. As I mentioned earlier, clients infected with tuberculosis can have either latent or active TB. Let's start first with latent. Latent is a non-infectious form of TB. Remember, there is a fence that the body builds around the bacteria, so it's not going to spread anywhere or cause any symptoms. This means these clients will have no symptoms and not be able to transmit it to anyone else. Latent TB will be diagnosed through a positive tuberculin skin test or a positive interferon gamma release assay. As you can see in the image here, the tuberculin skin test, or TST, is administered intradermally. A wheal or bleb is formed. Now, there are many ways to interpret the reading of this, but typically about 48 hours after administration, the healthcare provider is going to visualize the site. If there is a raised and reddened area, the client is positive for tuberculosis. In clients who are immunocompromised, an area of about 5 millimeters is enough for diagnosis. For clients living somewhere like a prison or homeless shelter where the population is very dense, an induration of 10 millimeters is sufficient for diagnosis. And for everybody else, 15 millimeters is the standard. It's important to note that when we do an X-ray of these clients' chests, they're not going to have any signs of TB. Remember, it's been walled off, so there is no spread of the infection to the lungs. In contrast to latent TB, we have active TB. Remember, this is highly infectious, but an important feature is that it's going to have a slow onset. Unlike pneumonia that takes a couple of days to show symptoms, clients may take weeks or even months. One of the biggest symptoms is cough, and clients may or may not have bloody sputum. They're often going to have fever and chills and very, very characteristically night sweats. These are going to become drenching night sweats in which the client wakes up drenched head to toe in sweat, and not just a little bit. Clients are going to have weight loss, and they're going to have fatigue and malaise. They're just going to be weak and tired because that infection is starting to spread across all of their organs. There's a couple different ways we diagnose active TB. The first is going to be through an abnormal chest X-ray. As TB begins to move across the lungs, it's going to be visible on X-ray. They're also going to have a positive TST and/or IgRA. Finally, it's very important for these clients that we do sputum samples. These clients are going to have a positive acid-fast bacillus sputum smear and a mycobacterial sputum culture. TB is very treatable when caught early and when the proper resources are around. Unfortunately, in resource-poor countries, there are just simply not enough medications and treatments to go around for everyone, and clients are often not able to access medical care easily or quickly. As a nurse, there are a lot of interventions you're going to do for a client with TB. The first is collect sputum cultures. Like I said, sputum cultures are going to help us diagnose an active TB infection. We also need to implement airborne precautions, so clients need to be in a negative pressure room in the hospital. You also need to wear a properly fitted protective particulate respirator mask, such as an N95. These are specially fitted masks that you can wear to help prevent the transmission of TB. They fit very snugly to the face, so particles cannot enter in. If clients need to be transported outside of the room, they should wear a surgical mask to help reduce the spread of infection to others. We want to minimize how often these clients move out of the room, so things like a portable X-ray at the bedside are going to be optimal for these clients. Nutrition is very important in these clients getting better. We want to encourage high carbohydrate, high protein diet with frequent small meals. The healthcare provider may consult a dietitian and something like a protein drink added on to help supplement the client's intake. TB is a reportable illness. We need to make sure that if we have a client with active or even latent TB, that they are properly reported to the health authorities. Local health authorities are going to follow up and make sure these clients receive treatment, and they may help participate in what's called directly observed therapy. Treatment for TB is often months up to even a whole year, and clients may have a hard time remembering to take their medication or even wanting to take the medication. In directly observed therapy, someone is directly observing the client taking the medications and logging that they have been taken. Ensuring compliance with medication is going to help make sure the client gets rid of the tuberculosis in their body and that they don't transmit it to any other people. As I mentioned, TB is highly communicable, so if clients are diagnosed, we need to test their family and close contacts. This could be roommates, this could be coworkers, anyone they're seeing on a frequent basis. We want to make sure that it hasn't spread to anyone, and if it has, that they receive proper treatment as well. Finally, tuberculosis is treated with a long-term 4-drug combination antibiotic therapy, and we need to make sure that clients take all 4 of the medications. These medications are isoniazid, or you may often hear called INH, rifampin, pyrazinamide, and ethambutol. Now, clients with active TB are going to be on 4 medications at once and for a while, so we need to make sure they understand the side effects and are able to properly manage them. It's important that clients wear glasses instead of contact lenses. Rifampin turns bodily secretions orange, and it can eventually stain contact lenses. We also need to monitor these clients for signs of hepatotoxicity. Isoniazid is very hard on the liver, and in lab results can often show increased liver enzymes. These clients will often require frequent laboratory monitoring of liver enzymes as well as things like electrolytes and blood count to make sure that the drugs are not affecting their body adversely. In addition to turning bodily secretions orange, rifampin actually interferes with how birth control works in the body. So clients need to be taught to use a backup contraceptive method or a non-hormonal method until treatment is completed. We'll talk more in detail about these drugs in our pharmacology videos. Finally, to see if the infection is improving or has gone away, we need to collect a sputum culture from these clients about every 4 weeks. Finally, let's talk about some teaching points for clients with latent TB. Remember, those with latent TB cannot spread the infection to others, so clients may not feel a need to get treated. We need to emphasize to the clients that if they become immunocompromised, the TB could reactivate and the infection become active in their body, and then they spread it to others. Treatment's not going to be as intense for latent TB, but it's still going to be several months long, often about 4 to 8 months. We're only going to use 1 or 2 drugs, and it's typically going to be isoniazid and or rifampin. Remember to still teach the client the same things about rifampin and isoniazid. With rifampin, they're going to have orange secretions, and they need to use backup contraception. And with isoniazid, there's always a risk of liver toxicity.